secondary bronchus. So we have the trachea and primary bronchi are the same. And then we have secondary and tertiary. And then we moved on to bronchioles, right? So for tertiary, and I put it tertiary because the first part of the secondaries are similar with the primary, so I want to make sure we're definitely in past the trachea primary bronchi characteristics. So tertiary bronchus, not a bronchiole. And I see 3 correct answers. 3? 3. Or only if you talk about the very end of the tertiary. So the characteristic.
So she said she got 4. But I found it 4. Yeah. Yeah.
But actually, it's not A, B, and E.
It's not? Wait, well, I wanted another one too.
So what's our respiratory epithelia? Pseudostratified columnar. Where do we find pseudostratified columnar? Where do we first find it? Nasal cavity. And then nasopharynx. And then we skip oropharynx and laryngopharynx. And we pick it up again in the trachea. Lower part of the larynx, but definitely in the trachea. And where else? Where's the last place? Not the last. We find it in the primary bronchus. And then it will start out the secondary, but it doesn't finish the secondary. Right? So just the first, as you move into secondary, you're going to continue to see pseudostratified columnar. But it's not the characteristic epithelia. So what would be the characteristic epithelia of secondary and tertiary? Simple columnar. And then at the end of simple columnar, as you transition into bronchioles, you might start to see simple cuboidal. Okay, but the characteristic epithelia of secondary and tertiary. It goes from the 2. So it starts with the 1 and ends with the other, but the characteristic is the 1 in between. Yeah. So it's like this much of either of the 2 that could, but the rest of it is being set. Yeah. Okay? All right, so at the very end of respiratory anatomy, we need to talk, well, we're not, we need to, but we're going to talk about the lungs. All right, we've looked at the internal structure of the lungs, and now we're going to look at the external structure of the lungs. And pleura, as we move into pleural cavity and talk about how we expand the lungs in our next pulmonary ventilation, which is what we'll spend the rest of the evening talking about. So, we have right and left lungs. And first of all, just basic components. Remember when we started talking about the heart, we talked about apex and base and right border and left border and so on. So with the right lung, we have regions and surfaces. So the pointed portion is called the apex. And that's what we call the pointed portion of the heart, but it was pointing in the opposite direction, right? And down here would be the base. Then we have the surfaces. So we have an alternate name for the base as a surface. It's facing the diaphragm and can come in contact with the diaphragm if you take a really deep breath to fill the air up with blood. So it's also known as the diaphragmatic surface. Then facing the mediastinal cavity, we have the, slightly, we have the, which surprise, mediastinal surface. And that would be in contact with the parietal pericardium of the heart.
That's so fun.
Uh-huh. Okay, now this also is the site, not the entire surface, but it's also the site where we have the hilum or hilus, which is the slightly indented region that contains the openings or the entrances and exits for the bronchi and the pulmonary veins and arteries and the bronchial arteries and veins. Okay? Now, you can see on the outer surfaces of the rest of the lobes of the lung, there's this rippling effect, and that's due to the ribs. So when we look at this sheep heart today, at a sheep pluck, you won't see that on the surface, but in a preserved lung, where it's been fixed, then you will see that, because it retains that indentation, not just for the ribs, but when we look on the mediastinal surface, we'll see the indentation for the vessels, the aorta, the superior vena cava, the xygous vein. So the rest of the anterior and posterior surfaces is known as costal. So I'll draw a dotted line in the back to show it's both surfaces. And costal, of course, means rib. So it refers to that region. Okay? Now, point to yourself where you think the apex would find its location after you've taken a deep breath. Where would the top surface of the lung be when you take it as deep a breath as you can? Inch and a half up into the neck. Yeah. Because you have the bony space, what's called the thoracic inlet or outlet, you know which way you're going. You have the ribs and the clavicle and so on, so that space is open. There's no barrier across that. What stops that is the pleura. Okay? And as you fill your lungs with air, that can move up, not all the way to the jaw. I was being facetious, but my figure's that high. So as I told the class last night, I'm always giving you hints that I hope will save your life. So we talked about where to have a cracothyroidectomy, an emergency airway. I talked to you about if you were trying to stab somebody trying to chase you down and you had an ice pick, where the best place was to stab them with an ice pick. That was not the thoracic, it was in the neck or the lumbar region, because the vertebrae are more horizontal. So let's say someone that took my class has now turned against one of you and from previous years, and they're coming after you with an ice pick, and they know where to put it because they took my class. That was for self-defense, and you haven't done anything to offend them. So they're coming after you. What you do not want to do, and I think this got on recording last night because Nate was sitting there, what you don't want to do is go, because then you're going to move your lungs up into your neck, and if it gets stabbed with an ice pick, you're going to have a collapsed lung. All right, so this is what you want to do. Squeeze all the air out, and that'll sink your lungs down into your thoracic cavity, and if you get stabbed in the neck, it won't get your lungs. Okay, so maybe they'll miss your spinal cord. 30 years and nobody's yet written me a thank you note. Maybe one of these days. Maybe I haven't actually saved anybody's life with that information. It wasn't helpful, but anyway, that's how far up, because of that pleura, will move up into the structure of the neck. All right. Now let's look at the separation, because we have grooves known as fissures. All right. Each lung has an oblique fissure, and that describes the angle at which the fissure cuts through the lung. Not completely. These are not completely separate from each other. They are connected towards the central region here at the hilus. And so on the right lung, we have an oblique fissure that we can see on its anterior surface, and posteriorly it continues to curve around towards the apex. All right, so I'm going to show that curvature with a dotted line. You can continue to follow it. All right. So where we see it here would be the oblique fissure, separating the the inferior lobe from the middle lobe, all right? I'm going to bring this forward a little bit more. So this is inferior lobe. And then we have on the anterior aspect, the transverse fissure. So this is oblique. This is horizontal. This is an anterior view. So let me draw this as a dotted line. It's a solid line. This is middle. And this is superior lobe. All right? So, for clarification, horizontal fissure separates superior lobe from middle lobe. Okay? Oblique fissure, and this is for the right lung, because the left lung doesn't have a horizontal fissure. Oblique fissure separates middle lobe from inferior lobe, but it also separates superior lobe from inferior. And it does that on the posterior surface, right? So on the anterior surface, all of this is superior lobe. Then we have middle and part of inferior. So that's what you're seeing here on the right lung. So you would have superior lobe. This has a pretty high horizontal fissure, middle lobe, and here's the oblique fissure, so here's inferior lobe. But when we turn it around, look how high up the inferior lobe goes. And then a small portion is superior.
Is this a posterior or anterior?
Now that's slightly lateral to anterior, because you're seeing a lot of the inferior, and most anterior you won't see any of the, notice how on that image,
Oh, okay, a little more.
yeah, it's kind of rolled, so your image is kind of rolled a little bit
So
laterally.
this is more anterior.
That's more lateral,
This is,
your image,
this one's
because,
anterior lateral?
yeah,
Right,
you're
okay.
looking kind of this way. You're seeing anterior definitely, because you're seeing the horizontal fissure.
And you're saying that, what rank on this?
So what you're seeing is more like this, because you're seeing all of this inferior lobe. So in the back, superior lobe and inferior lobe are separated by oblique fissure. They don't meet in the front, because the horizontal fissure separates it. Right? But if you look in the back, posteriorly, there's still superior lobe, but most of the posterior surface of the lung is inferior. So if you were to place your hand on someone's back at their scapula, that's going to be superior lobe, all right? If you're listening to breath sounds with a stethoscope, anything below the scapula is going to be inferior lobe. So pneumonia, cases of lung infection because of lying in bed, and gravitational flow tends to be occurring first in the inferior lobe, all right? So if you're listening to wet breath sounds or rales because of fluid in the alveoli, you're going to more likely hear that on the posterior aspect of the inferior lobe because of the drainage. Alrighty? So now we only have one fissure and two lobes in the left side, similar to the two leaflets of the atrioventricular valve. And so here would be the oblique fissure and then going posteriorly. So we only have one fissure, so whether it's anterior or posterior, it's going to separate the inferior lobe from the superior. And this is the oblique fissure. So all we have on the left lobe is this, okay? So left lobe, oblique fissure separates superior and inferior. Right lobe, oblique does both of these. Okay? Because we have the three lobe components. It just depends on whether you're looking at the front or the back. All right, so now let's place, and you can see here through, and then see through, that we have the right bronchus, and then we have this bronchus, and this one separates into two major bronchi to separate, to supply the lobes. Now let's add on the pleura. So here you can see that in blue, the parietal pleura is not, extends farther than the actual lung tissue. and that's for the purpose of allowing for lung expansion. It provides the greatest extra room inferiorly. All right, so we have about 2.5 to 4 inches of extra room below the lungs for expansion rather than above the lungs. So I'm going to redraw this because of all the words and letters on there and put in the pleura if you want to. I don't think the green shows up that well, but all right, so do you remember from the end of lecture on Tuesday night, we talked about surface tension. We started talking about surface tension in the alveoli between the wet surfaces of the alveolar wall. What was the effect of surface tension between the visceral and parietal pleura? Surface tension due to the formation of extramolecular, intermolecular hydrogen bonds. Was that advantageous or disadvantageous to have surface tension hydrogen bonds forming in the pleural? Advantageous. So the two wet surfaces connected by hydrogen bonds move your ribs and diaphragm, then that helps to expand the lungs by pulling on the visceral pleura through those hydrogen bonds. And only because there's so many of them, because each hydrogen bond is rather weak. All right, so let's look at the placement of the pleura now. Oh, I already erased it, but let me go back and talk about one more thing. And I drew an indentation in the lung, which is deeper. The indentation is present on both sides. It's called the cardiac notch. Let me go back and show that to you on the previous, because I forgot to mention it when I was diagramming it. So this indentation is the cardiac notch. There's also one on the right side. It's just not as prominent, okay? Because the heart is more on the left than it is on the right. And so this indentation creates a narrowing of the superior lobe. On the left side, it's not present on the right. And this reminded somebody of a tongue. So this narrow portion right here is called the lingula. Lingla, right? So it's, well, I can't show it to you because the anterior aspect of the left lung is absent. But it's because of that deeper cardiac notch in the left lung. Attaches via loose irregular connective tissue to the lung, and it is a simple squamous epithelium. So there would be our lung alveoli, all right, simple squamous epithelium of the lung alveoli, and then loose irregular connective tissue, and then a serous membrane of simple squamous epithelium. In fact, we have an older alveolar air sac model, because it's difficult to see on the new one. It had the large alveolus I showed you on Tuesday. This one. And so these simple squamous epithelia that you see on the surface here is representing the visceral pleura. Okay? So it's secreting that watery fluid. And I'm going into a pantry over and over. Back here we have a freeze-dried lung that we've had since I started teaching here 22, 23 years ago. It's a sheep lung that used to be on a stand, and I'm going to pass it around because if you look carefully, you'll see thin little pieces of tissue, especially in the fissures, that are hanging off. So don't pull on them, there that people won't be able to see anymore. And even on the anterior surface, that's where the visceral pleura has separated from the lung. And that's how thin it is. Okay, it's like you got your hand sunburned, and when I was a kid, we'd get sunburned playing at the beach, and then we'd try to peel the skin off ours, see how big a piece we could peel off the back of our hands. We're very healthy exposure to the sun. And so that's what it reminds me of, it's that thin, okay? All right, so that's our parietal pleura, our visceral pleura. And you'll be able to see that on our sheet plot today. Feel it. And then when it gets to the hilus, where the bronchi and the blood vessels are, folds back on itself, and I'm enlarging the actual space here. I'll bring it down a little bit down here. And this would be the parietal pleura. And the only thing we find in the pleural cavity is serous fluid. The lungs are not in the pleural cavity, because that's a closed space. It's like pushing your fist into a balloon that's been blown up and tied off. You're not actually putting your hand into the balloon. It's collapsing around your fist. So that would be a closed space that has room for the lungs to expand, similar to our pericardium, having room for the heart to expand. And we have stress receptors in the lung tissue that fire to stop you from breathing out, breathing in too much, so that we don't pop those alveoli. All right? So we're going to look at the pressures that are present in the pleural cavity after we talk about the muscle tissue. Go back to Bio 430 and talk about the muscle tissue that helps us expand and change the volume. So this is a video of internal aspects of the ribs. You're not actually seeing the ribs here, but what's covering it is the parietal pleura. So here would be the alternating rib, and deep to that would be the intercostal muscles. Skin would be on the other side, and here's lung tissue. Okay? So that when you open up the pleural cavity like that, the lungs get smaller because atmospheric pressure is pushing them close, so they don't have the negative pressure and changes the respiration and keep them open.
So the parietal pleura is also attached to the ribs?
Yes.
Okay.
Yes. The parietal pleura, thanks for bringing it up. The parietal pleura is attached to the ribs and to the diaphragm. So down here, it would be attached to the diaphragm. So that would be part of the expansion, is the diaphragm pulling away and the ribs pulling away. They actually move. The pleura itself. Okay?
Is that the simple squamous?
The simple squamous would be facing the inside of the cavity, and the connective tissue outside would be attached to the diaphragm muscle, connective tissue of the muscle. Okay? And then out here, you would have the ribs. And skeletal muscle. Alright, so here's a look at the medial surface, or the medial spinal surface. One reason you can tell that this is a more lateral view is you cannot see this mediastinal surfaces. It's been rotated laterally. So here we're looking at the mediastinal surfaces in the hilum, or hilus, where the airways and blood vessels pass through. And you can see the pattern here. Here would be the trachea, and anterior to it would be the pulmonary veins and the pulmonary artery. Now on the right side, the pulmonary artery, which remember is carrying deoxygenated blood, is anterior, stays anterior to the bronchi and superior to the pulmonary veins. On the left side, the left pulmonary artery arches over the left bronchus, and the sets of pulmonary veins though still stay anterior and inferior. So when we look at that in a cross section, this would be the right lung. The bronchus is posterior to the pulmonary artery, and here are the pulmonary veins that are anterior. All right, so again, we were looking at this. So the bronchus is posterior, pulmonary artery anterior, and veins inferior. All right. When we look at the left here is the bronchus. Here's the pulmonary artery going over it, and here are the pulmonary veins. So here we have the pulmonary artery is superior, bronchus is inferior, and the veins are more inferior than that. So notice what we see here. Again, here's the bronchus, here's the trachea. Here would be the phrenic nerve going to the diaphragm, okay, and vagus nerve going to the heart after it's given off branches to the lungs. And here we have the azygous vein arching into the superior vena cava. Here we have the aorta arching into the, arching out of the heart as it leaves. So when we look at those impressions, we can see them as well. So here would be the superior vena cava, and here is the azygous. It looks big enough to be the aorta, all right? But if we look carefully, we can also see that we have 3 lobes, 2 fissures and 3 lobes. That's the easiest way to tell that you're looking at the right lung, is the number of lobes. But if you can't see that, then you can go by the, and this is difficult, so we're looking at the common carotid here, or the superior vena cava. Is this the azygous, or this is the aorta? Because if we look at this view, it looks similar. All right? So if all you have is this, without the fissures, then you can go by the relationship between bronchi and bronchus, primary bronchus, and the pulmonary artery. Okay? So right lung, pulmonary artery is anterior, left lung, pulmonary artery is superior. Okay? And if you forget, you can come back to this diagram and see the reasoning behind that. Now, do you see something else in this diagram here, looking from the left side towards the heart? Something that we talked about on Tuesday, when we talked about the larynx, which we can't see in this picture. But we talked about the innervation of the larynx, right? The vagus nerve. And remember, we had the recurrent laryngeal nerve, and here it is, curving around under the arch of the aorta. I talked about an aneurysm causing that to stretch, resulting in symptoms of hoarseness up in the larynx, even though the problem was down in the chest cavity. All right, so a swelling, a ballooning of the aorta here will stretch that recurrent laryngeal nerve as it comes back up to all the muscles, including vocalis muscle, and will show up as hoarseness up here rather than any symptom down here for a while. Okay, question number 3. We talked about somebody choking and the fact that typically food is caught in the spasm of the vocalis muscle, so within the vocal ligaments. Here we have the hyoid bone. Here's the thyroid cartilage, cricoid cartilage, and trachea. So where is the best place to do an emergency opening into the airway? By emergency, I mean you're not in the OR. Yeah. The sharpened pencil, pen, Costco hot dog, whatever. So it's up to you. You don't have an OR to use. Where would be the best place? So you need to think about where the vocal ligaments are, where the blood vessels are. Stay away. You need to be below the vocal ligaments, and you want to stay away from all the bloody vessels in the thyroid gland, because you're not in an OR. Remember I said you tilt your head back and you run your finger down and drop into a groove? That's the groove I'm looking for. Okay? would do a regular in surgery
Okay.
tracheotomy.
Yeah.
But emergency wise, do you remember two reasons? We're definitely, up here would be above the vocal ligaments, so you're not gonna do any good if that's where the spasm or the blockage is. We go here, two things. The posterior wall of the trachea is soft tissue. You're just jabbing in there, you go right through into the esophagus, okay? Major reason is the gland has a lot of blood vessels. It's just gonna be a bloody mess, and you're just gonna have blood pouring down the trachea. So if you go in this area here, then you're gonna hit the back of the cricoid cartilage. You're not gonna go into the esophagus. Plus you have much fewer blood vessels than you do trying to get through the gland. So then this is done in an OR. They cut that, resect it, cauterize or tie off the vessels. And they do it slowly and, for not a quick access. All right. That wasn't an actual question, so let's switch to, I mean, it's a question, but not one of our quiz questions. So let's switch to topic for tonight. Remember we said introductory on Tuesday, we had the phases of gas exchange, and I said we were gonna do the first three. The last one was cellular respiration at the mitochondria, where we actually use our oxygen and make our carbon dioxide. We covered that with digestion, okay? So tonight we're looking at pulmonary ventilation. In fact, the last thing we'll talk about is the formula for pulmonary ventilation and alveolar ventilation, what the difference is. So this is our mechanism for moving air into and out of the lungs, all right? Some of the rules that are involved, some of the procedures that are involved, and how we measure that. So our lab on Tuesday next week, we'll be using BioPack. It's not a physio-X thing, it's a computer model, not even a computer model. We have computers and these little black boxes, and you're gonna calibrate your own breath and blow into and out of syringes, large bore syringes, and the computer will measure your breathing for you, okay? So something a little more personal. I don't know if you're doing the like a spirometer, but it's more, can do a little bit more. Our regular spirometers that I show you can only do by expiration, and this does both inspiration and expiration. All right, question 4. Quick turnaround on Hilo. So look where the bronchus is. I actually labeled the bronchi and the blood vessels for you. So we talked about it. We talked about the superior bronchus versus the anterior bronchus. That's what you're paying attention to. All right. So the bronchus is black, and you're in the back of the room and can't read that small print. Pulmonary arteries are the purple because they're deoxygenated. So it's this relationship you're trying to determine. This one is pulmonary arteries are anterior to the bronchus. The other choice would be superior. Then you have to figure out whether it's right or left based on that relationship. I'm going to leave the lung picture up here, but I'm just erasing the words to give me a little bit more room for our muscles that are coming out. So what's a granzyme? Half your brains are thinking about the blood and immune system, so I just thought I would check in on that side of your brain. 2 cells that release granzyme. Okay, natural killer cells, and the other? T killer. All right, you're on it. Some of you anyway, the answer. All right, question 5. So which of the following cells is also known as an alveolar type 2 cell? This is what you're looking at here. So the light microscope, and here in the low-powered electron microscope, these are the lipid, and the lamellar bodies, and if you fall off the skin, but it's still lipid, which should be included. You might see one or both of those images on the quiz next. So right here, light is kind of fuzzy, but it's more of this. Type one.
With the zebra print on the side.
Yeah. So this cell is all of this,
Oh, that whole thing is
the
fresh.
whole thing.
Oh, wow. So those are droplets of liquid.
Uh-huh.
The little white circle.
Right, so a little line to them. So what's another name for C? Is it suckle cell, or that's this one? Is it type 2 or type 1 or something else? It is. And what is it something else? So these cells eat your dust.
Oh, yeah.
So dust cell.
Oh, that's.
So as particulate matter enters into your respiratory system through your nasal cavity, the wet fluid of your nasal cavity that's moistening the lung also sticks to the larger dust particles, and the hairs help to filter it out. As it moves into your trachea and bronchi, it sticks to the mucus. But even fine particulate matter can still move deep down into the alveoli, and the macrophages are there to ingest them. Okay? Alrighty, so finally, 45 minutes in a class. Pulmonary ventilation. So pulmonary ventilation is moving the air into and out of the lungs. So if you were to open your mouth, not contract any muscle, just open your mouth. Is there any air moving in and out? No. So to either move air in or to move out, we need to change pressures. We don't suck air in, we lower the pressure in the thoracic cavity so that atmospheric pressure pushes air. And then we want to exhale, we decrease the volume of the thoracic cavity so the pressure goes up and we push air out, all right? So breathing is a reversal of pressures, pushing the air in and pushing the air out. So we have two sets of muscles that are the primary inspiratory muscles, or inspiratory. And these are going to function to increase the volume of the thoracic cavity. So we have the external intercostals, and those are superficial to the internal. This is a review of File 430. So intercostal means between the ribs. So they are found between the ribs. And their function is to lift the ribs up. MM is my abbreviation for plural for muscles. All right, so the ribs only lift a tiny bit, but that changes the front to back distance. So the common illustration is a handle of a pail that's lying down the side of the pail. And you need to lift up the handle, and as you do so, you move it away from the side of the pail. All right? And so that moving the ribs like that increases the front to back distance. So external intercostals are going to have their origin on the superior rib and insert, that's our movable point of attachment, on the lower rib. Okay? So each set of ribs is lifted up. So the pattern of these ribs on the right and left sides is like this. So you can put your hands in that position and lift. Alright? We'll see the reverse for internal costals because they pull down. So external costals lift up. Again, origin is superior rib. And movable point of attachment insertion. The movable point is the inferior rib. Alright, and this functions to increase anterior posterior distance. What's the nerve for the intercostal muscles? Very difficult to remember, which is why you've all forgotten it. told you guys the story about when I was taking cadaver dissection with the medical students for graduate school, those of you that had me last semester. And our exams were on the cadavers. And there were multiple choice, but they were difficult enough that our professors thought we needed 2.5 minutes per question. And so it wasn't just name this muscle or name this nerve. So the obturator internus muscle was tagged, and the question was, identify the nerve that innervates this muscle. So you had to know what the muscle was and then what's the nerve that innervated it. And like I tell you guys, I always try to come up with the answer first and then confirm it by finding the answer in the list. So for over 2 minutes, I sat there going through all the nerves I could think of, rejecting each one. No, it's not that one, it's not that one. Finally, with about 15 to 20 seconds left before I had to move to the next table, I looked at the answer list. Never forgotten it. The nerve that innervates the obturator internus is nerve to the obturator internus. All right, so the same nerve is going to innervate our internal intercostal, but for respiratory, we're going to move to the next muscle, which is the diaphragm. And this one is bell-shaped or bowl-shaped. Origin is off of the lower ribs. So it's shaped like this. And at the top is a white, almost figure eight, close figure eight shape, which is the insertion, known as the central tendon. So the origin is the lower rib. The insertion is the central tendon. So when the diaphragmatic muscles contract, it drops down the middle of the diaphragm like that. And that increases our superior to inferior distance, okay? So between these two sets of muscles, we increase the thoracic volume this way and this way. What happens to pressure when we decrease volume without changing temperature? We have the same number of gas molecules, but they have more room to move around in, so pressure is going to decrease. And therefore, atmospheric pressure, which stays the same, we're not bouncing up and down 5,000 feet each time we breathe. So atmospheric pressure stays the same, and as we lower the pressure in the thoracic cavity, now when I open my mouth or I move it through my nasal cavity, it's lower, atmospheric pressure pushes air in, okay? So if I move those external intercostals of my diaphragm, air is going to move in until the pressures are equal again. So if I open my mouth, no air moves. As I contract those muscles, air will move until I stop changing the volume, and then it equilibrates and air doesn't move anymore until I increase the volume further or decrease the volume and push the air out. All right? So nerve, the diaphragm, phrenic nerve. Remember that from our blood vessels. So the intercostal nerves don't form a plexus, all right? What we're calling the intercostal nerves are ventral rami, the anterior branch of each spinal nerve between the ribs. Phrenic nerve comes off the cervical plexus. In fact, there's a phrase that C3, 4, and 5 keep the diaphragm alive. So the ventral rami of those spinal nerves come up pretty high. We only have 2 spinal nerves above them, right? So fracture of the spinal cord, damage, separation of the spinal cord above C3 means that there is no connection of upper motor neurons to lower motor neurons for breathing, all right? Because these muscles that we're talking about, are they smooth muscle or skeletal muscle? Is breathing voluntary or involuntary? Let me change that. Is it autonomic? Is it general visceral efferent or general somatic efferent neurons? Are we using sympathetic and parasympathetic, or are we using voluntary neurons? So, voluntary or involuntary? How many for involuntary? Involuntary? Okay. How many for voluntary? Okay. Stop your heart from beating for 2 seconds. Can't do that. Hold your breath for 20 seconds. You can do that. So the reflex is what you're thinking of for involuntary, what we'll talk about next week for our control of respiration, okay? So the reason you can fall asleep and not have to stay awake and breathe is because the drive to breathe from our brainstem is based on changes in carbon dioxide level. Well, we do have a generator, a pattern generator, but also changes in carbon dioxide level, all right? But that then sends neurons that activate the lower motor neuron cell bodies in the spinal, cervical spinal cord for phrenic nerve and thoracic for intercostal. So if we separate the spinal cord between C2 and C3, we can't reach those neurons that are actually going out to the muscles. So you would have to have someone, if you fall off a horse and damage between C1, C2, or C2, C3, you're gonna stop breathing if there's somebody not right there to breathe for you, okay? So this is active inspiration. And then we have accessory. So these muscles that you see here, and I talked about all of them in Bio 430 except the scalenes, and I'll show them to you in a moment. These can be used for what you need to take in a deeper breath than you normally do for everyday living, and then what you can do with the forceful components. So the bottom, these two right here, have their normal origin on the ribs and insert onto the scapula. They both function to rotate the scapula forward, okay? So pectoralis minor I call the I pledge allegiance muscle. Starts from ribs 3, 4, and 5, attaches to coracoid process and pulls the scapula forward. Serratus anterior does the same thing from the ribs to the scapula and also rolls the scapula forward. So to use it to lift the ribs, we have to flip our origin and insertion. We fixate, we stabilize the scapula by using other muscles to not allow the scapula to move. And then we can use those ribs to those muscles to lift the ribs, and we switch our origin and insertion. The ribs now become the insertion instead of the origin, okay? Sternocleidomastoid has its origin from the clavicle and the sternum, and it moves the head. But if we keep the head stable by using our extensor muscles not allow it to move, then we can lift up our sternum, okay? It helps with increased volume. The scalenes, you can see right here, that's the sternocleidomastoid. This scalene goes to the first rib, which isn't going to move very much, and these go to the, that's not the scalene, that's sternocleidomastoid too. This scalene goes to the first rib, and the other two scalenes go to the second rib, which moves more than the first rib. So those are of limited use. They're more helpful as a marker for where our brachial plexus goes into our upper limb, all right? But because they attach to the ribs, they are accessory respiratory muscles. So all of our accessory inspiratory muscles attach either to the ribs, these first three, or to the sternum. Okay, that's how they can help if we change their points of movement. All right, muscles for expiration. Take in as deep a breath as you can, and then just let it out as a sigh, okay? Did you use any muscle contraction when you were sighing? You were allowing your respiratory muscles to relax. And as they relax, the ribs settle down, the diaphragm muscles relaxed and came up, and that decreased the thoracic cavity volume. No contractile force, no ATP was used in shortening. ATP was used to move calcium ions back into the sarcoplasmic reticulum, but not to contract the muscle, okay? So expiration is a passive process. When does it become active? When you're blowing up balloons, okay? So when you're actively forcing air out, so now breathe out more. You can feel muscles contracting, okay? So as you just sigh, that's relaxation of the inspiratory. Now when you continue to move air out, beyond that, passive sighing, now you're using muscles, okay? The primary active expiration muscles are the internal intercostals. So I'm going to erase our inspiratory muscles up here and just write a little bit about the internal. Abdominals, we just contract our obliques and our transversus abdominis, a little bit of the rectus, and that just decreases the volume of the abdominal cavity and pushes up the pressure on the diaphragm. It just pushes the diaphragm up higher, okay? So may I erase the muscle information over there? You guys have that?
Did you say the intercostals are the primary active or?
External are the primary inspiratory, internal are the active expiration. All right, so we'll put have no, otherwise it's passive. So accessory might be a better word here. So we'll change external to internal. And we'll change the orientation of the fibers. They're at right angles to the external. And they happen to come all the way to the sternum. So the fact that the externals start 1.5 to 2 inches lateral, we can see the internals, just lateral to the sternum. Their fiber direction is the reverse of the externals. And it works if we take our hands like this, we pull down, okay? So externals lift the ribs up, internals pull the ribs down. What we're going to do here is switch origin and insertion, since they're pulling the ribs down. The insertion is going to be the superior rib, and the origin is going to be the inferior rib, okay? We're moving the upper rib. For breathing in, we were lifting the lower rib. But the nerve is still the internal intercostal. I'm sorry, just intercostal. So now we raise diaphragm. That's not an expiratory muscle for active anyway.
The inferior intercostals,
Internal.
internal.
Internal intercostals are decreasing the front to back.
Okay.
So yeah, I need to change that too. Thank you. So the only muscles we have that are actively involved in expiration are accessory. We don't use muscles typically in just normal breathing in and breathing out. Breathing out part, we do for only for breathing in. So here's an illustration of what happens to the density of the air, all right, when we change the volume. We'll look at this as well because changing pressure also helps to increase the amount of gases that dissolve in our blood. And we'll look at that next week when we talk about external and internal respiration. Here's another illustration. So we push down, and this used to be animated. I probably copied it too many times, so I lost the link. But when we push it down, the pressure gauge goes up because of closer, smaller volume. The gas particles are more likely to bump into each other and against the wall and increase interaction. We increase the volume, they're less likely to bump against each other and move and bump against the wall, so pressure goes down, okay? Notice temperature has to remain constant because that's going to affect their movement as well. It's going to decrease the movement, lower the pressure, increase the density, or it's going to increase the movement, the likelihood of hitting each other and increase pressure. So when we look at the airways, okay, when the diaphragm is up, thoracic volume is lower and pressure is higher. When we lower the diaphragm and raise the ribs, volume increases, the pressure around the airways drops, and atmospheric pressure becomes greater than intraalveolar pressure, okay? So there's a very classic, we used to have 3 or 4, Lab Tech borrowed one last night, so let's see if we can put one back. There we go. I didn't think to use this last night. You guys are fortunate being the second time around. All right, so the 2 balloons are your lungs. And you can see the little plastic tubing that's split is the trachea and bronchi. And the plastic dome would be your chest wall. And the rubber diaphragm is the diaphragm. So we're not using the intercostal muscle illustration here because we're not changing the diameter of the wall, all right? So the only access is the air going into the balloons. There's no air available to go into the dome space, all right? But, so now the diaphragm is pushed up. As I lower the diaphragm, look what happens to the balloons. Because I've changed the pressure around them. There's an increased volume available in the dome. The same number of gas molecules, so there's no place for a gas to move in or out. And so the pressure around the balloons has increased, and that allows atmospheric pressure, the gas out here, to move in. Okay? So that's what we do when we change the volume of our chest wall. Allow atmospheric pressure to push in, change the volume, push the air back out to the atmospheric pressure. Right? So that's the purpose of what we're doing with the muscles that we went through up here.
Can we go over, you said the diaphragm will go down, the ribs will go up, that equals an increase in volume, so the pressure in airway goes down, and then what was
The pressure around the airway goes down.
Pressure around.
And that means that there's atmospheric pressure then can push air through the alveoli, or into the alveoli. But the pressure in that, I mean, yeah, pressure in the alveoli goes down too, as we'll see when we look at this. So this is why I left the diagram up on the board. So let's talk a little bit about atmospheric pressure first. Can I erase this up here? Okay. So the most numerous type of gas molecule in the air is nitrogen. We'll look at those compositions on Tuesday next week. About 79, almost 80%. And oxygen is about 20.9%. All right, a lot of people say 21, either 20 or 21. But carbon dioxide and hydrogen's in there too, so they're to give room for those smaller fractions. Do gas molecules have mass? Does a proton weigh anything? What's the atomic number for oxygen? 16. So how many protons does oxygen have? 16. So do protons have a mass? Yeah. So oxygen has a mass. Hydrogen has a mass. Nitrogen has a mass. And if you wanted to prove that to anybody, all you have to do is just take your hand and move it through the air. You feel resistance? That's the reason a sailboat moves, all right? If it was in a vacuum, there would be no wind. So when we see wind, it's because of gas molecules moving from high pressure to low pressure, and you would feel no wind on your face or on your body if there was no mass there. So that's where we get our atmospheric pressure from, is the mass of gas molecules around us. We draw, it's given in torr or millimeters of mercury. I wrote it with millimeters of mercury, so that's what I'm going to do. So to illustrate that for you, let's have a shallow tray of mercury. I promise we won't spill any. And we're going to sit this on the sand, so we're at sea level. And we're going to place a tube, a closed tube, inside the mercury. And the tube is in a vacuum, or it contains a vacuum. There's no gas, there are no gas molecules, there's nothing in the tube, all right? So that's a vacuum tube at this point in time. Have you seen the videos of the illustration of the fact that a feather falls at the same rate as a lead ball in a vacuum tube? They have a huge chamber, as big as diameter around as this room. They close these heavy doors and turn on pumps and create a vacuum. And then they drop the feather so there's no air resistance, because the feather is going to fall slowly because of air resistance. So this isn't quite that huge, all right, but no gas molecules in there. Now, surrounding this, because you have to be able to live to do this activity, we have nitrogen and oxygen and hydrogen and carbon dioxide gas molecules. Now, if you look at sea level, are these going to be at the same concentration as at 8,000 feet elevation? No. They're going to be lower or higher at sea level? Higher because of? Gravity. So gravity pulls, just like the reason you fall off a tree. Gravitational force is pulling you towards the ground. All right, gravitational force is pulling on the gas molecules because they have a mass. The farther up on Mount Everest, they're farther away from the center of the Earth, so they're farther away from that pull of gravity. All right, so we have fewer gas molecules as we move up in elevation. Why it's harder to breathe. You take in the same volume, 500 mils of air, you're going to have fewer gas molecules within that. All right, these have a mass. So as they're being pulled down, they're creating a downward pressure on that mercury. That downward pressure pushing on the mercury, the only place it has to go is up the vacuum tube. All right, so at sea level, it rises up the vacuum tube 760 millimeters. Okay, so that's a simple illustration of what we mean by atmospheric pressure is 760 millimeters of mercury. Right, now if we take this same measurement to Death Valley, which is below sea level by about, I don't know, 30 feet or so, would the atmospheric pressure go up or down? Up, because we're that much closer to the center of gravity. If we take it up to Mount Whitney, it's going to drop, okay, because there's fewer gas molecules, oxygen and nitrogen and carbon dioxide being pulled onto that surface, pushing it up into the vacuum tube. Alrighty? So, atmospheric pressure. We're about 50 feet above sea level here, depending on what part of Sacramento or the surrounding area you're in, but we'll assume sea level, okay? So atmospheric pressure around our body (760 millimeters of mercury). Okay? If I open my mouth, what's the pressure inside my alveoli? If all I do is open my mouth. 760 millimeters of mercury. Okay? So to allow atmospheric pressure to push air into my alveoli, I have to lower it. And I lower it by moving my diaphragm and my chest wall. All right? So you have this illustration somewhere, I think, in your lecture notes. So here's atmospheric pressure. The red line is intraalveolar pressure, or intrapulmonary pressure it's called sometimes. Notice it doesn't have to go up very high or go down very high for air to move in and out of your lungs. Anywhere from 1 to 4 millimeters. Okay, not a whole lot. So when you open your mouth, or your nose, which is easier to see, intraalveolar pressure, or intrapulmonary pressure, will go up or go down by a few millimeters. How much? Depends on whether you're using your accessory muscles, all right? Really trying to allow the atmospheric pressure to put in, or just doing panting. So that's going to vary. All right, but we have a closed space, hopefully it's closed anyway, that surrounds the lungs, and that's in the pleural cavity. So that's called intrapleural pressure. That is always, unless there's a tear in the pleura, that is always less than intraalveolar. Okay? And it's always less than atmospheric. That's another factor that helps in the expansion of the lungs. There's a negative force keeping the lungs from their natural recoil. All right, so it helps to expand the lungs. So this is a -4. So here's intraalveolar, going up and down. All right, so when it's less than atmospheric pressure, are you breathing in or breathing out? Atmospheric pressure, air goes from high concentration to low concentration, just like blood. So if intraalveolar pressure is less than atmospheric is 760, intraalveolar here we would say is 756, 758. 760 is higher than 758, so it's going to push the air in. Then, intraalveolar pressure now is 762, 763. It's now higher than atmospheric pressure, so it's going to push the air out, going down the pressure gradient. Air is going to move out of the lungs. So airflow is always going to go like a wind from high pressure to low pressure. So here, pressure is lower than atmospheric pressure, air goes into your alveoli. Here, pressure is higher than atmospheric pressure, pressure goes out of your lungs into the atmosphere. Does that make sense? Okay, if it doesn't, just keep reminding yourself that the higher pressure is pushing the blood, the higher pressure is, the air is going to go from high pressure to low pressure. Okay? And the intrapleural pressure is less than alveolar, so it's going to help to keep the lungs expanded, in kind of a negative sucking force. Okay? So we have the surface tension, the water, intermolecular water hydrogen bonds between the visceral pleura and the parental pleura, keeping the lung expanded. And now we have that negative intrapleural pressure helping to keep the lung expanded as well. Remember that picture I showed you of the parental pleura and the lung was just a little piece up in the corner? And we just saw that parental? That's because the pleural cavity was open and the intrapleural pressure became equal to atmospheric pressure, and the natural elastic recoil fibers of the lung allowed it to collapse. Okay? Obviously the person wasn't breathing anymore either, so we're not changing that. And if they were breathing, it wouldn't work with the lung thoracic cavity that open. All right, so let's say that we have some kind of trauma to this lung. We're going to do that in the sheep pluck today in our lab activity. I'm going to take a pair of scissors and gouge a hole in it. We were fortunate last night. The lungs were intact, because sometimes when they're being butchered, the lungs get slashed. And I noticed, I hadn't seen it before, but the lab tech put it up with about 10 hemostats. And that's to try to close all the cut surfaces if they happen, because it doesn't work very well when you're trying to move air into the lungs and it just leaks out of all the holes. But we had an intact lung, and then I illustrated what we call pneumothorax. And so let me show you that after we answer. This is the last question for your slides. So expiration. That should be I changed the question. I should change this. Last night I had inspiration. So expiration is occurring at A or at B. An expiration, as you've forgotten, is air moving out of the lung. Another word for it would be exhalation. Exhale. Because this is the range.
Oh, that's the range. Okay.
Atmospheric pressure isn't changing. Your last minute check to make sure you have your name. All right. So here's an image of what happens to the lung when air is allowed into the intrapleural cavity. This can occur from, I had a student whose young daughter would just randomly get torn visceral pleura. So the surface of her lung, little blebs would form, and then they would just tear. And there would be a gas removed from her alveoli into the pleural cavity space. Normally what happens is an accident, okay? So let's say you're in a traumatic accident and the ribs have broken, the skin's not torn, but the ribs have broken and have torn the visceral pleura, all right? So now when you increase your thoracic cavity, and intraalveolar pressure drops, and air moves into the lungs, all right? It's going to move into the alveoli at lower pressure, but now it's also going to have access to the pleural cavity, okay? So now, can we get rid of it when you breathe out? What happens to intraalveolar pressure when you breathe out? It increases, right? And we're moving air from the alveoli out the airway to the surroundings. Well, if we're increasing intraalveolar pressure here, it also moves air not only out the bronchi, but it moves air out into the pleural cavity. So whether you're breathing in or breathing out, you're pushing air into the pleural cavity, all right? Sounds a little bit like our cardiac tamponade. And with cardiac tamponade, with increased fluid in the pericardial cavity, there is less room for the ventricles to fill. So same thing with the thoracic cavity, the pleural cavity. With increased air, that puts external pressure on the lungs and they can't fill, and they gradually get smaller and smaller, okay? Now, you can exist with one lung. It limits your activity. My father-in-law got pneumonia when he joined the Navy, World War II, and the war was over within about 18 months, but he spent 12 of those months in the hospital with pneumonia, and had 2 lobes of his right lung removed. And he lived till he was 86. So that's not a death sentence in itself, but it becomes an emergency when that increased pressure affects heart function. So that increased intrapleural pressure can put a force on the heart and limit the ability of the heart now to expand because of the higher pressure around it. And that's called a tension pneumothorax. Okay? You can see here how the heart is normally more on the left side. Okay? So tension pneumothorax on the right side will shift the heart even more this way. Tension pneumothorax on the left side can shift the heart to the midline. It's usually because it's usually mostly the right side that's right under the sternum. So that becomes a medical emergency. And what's typically done is chest tubes can be used to release fluid. So you can have a hemothorax where you have blood in the pleural cavity, all right? And so a chest tube can be used to provide air is going to move going to float up. So it usually has a water valve because the air, once it passes through the water, is not going to come back down through the water. And I told last night's case, back in the late 90s, I read a story. Actually, I saw it on the news, and I've since searched. There's too much on the internet now to find something from 30 years ago or 28 years ago. But this young woman from United Kingdom, from England, had gone to Singapore for a short vacation, and met a love interest over there. And he took her back to the airport, and on a motorcycle, so she must not have had much luggage. And on the way back to the airport, they were involved in a crash. So she's banged and bruised up, but she gets to the airport, and the gate attendant say, are you sure you still want to fly? You don't look very good. And she says, no, I've got to fly. So she gets on board on the flight. They take off, and they're about the halfway point where it's just as far to go forward as to turn around and go back. And she leans over to get something out of her bag and feels this sharp pain. And she fractured her ribs, and then leaning forward, it had punctured her lung. Okay? And airplanes, jetliners are not pressurized to sea level atmospheric pressure. I think it's about 8,000 feet. And so most of us could deal with that, unless you have COPD or something. And so she started to develop tension pneumothorax. So they called for some doctors. One was an OB. I don't know if you remember his medical training very well. But they worked together. They called for a clothes hanger, metal clothes hanger, bottle of water. I have no idea what they use for a tube because straws are too flimsy. And of course, ubiquitous shoestring. Can't do anything without shoestrings. They used the clothes hanger to puncture a hole between her ribs and the mid-axillary line, connected whatever they used for a tube to the bottle of water, and I have no idea how they used the shoestring, but they created this improvised, this chest she breathed out, then the pressure pushed the air up the tube into the bottle rather than pushing it into the lung tissue, into the pleural cavity. Now what if your external damage, say a broken steering wheel, or a spoke from a bicycle or whatever, damages from the outside? Okay? Now this is what causes the bubbly, come upon an accident and this person's, every time they breathe, the wound is bubbly. That's because air, the lung, not just the pleural cavity, but the lung tissue has been damaged, the visceral pleura has been damaged, and now when they breathe in, air comes in from the wound, and when they breathe out, air is going into the pleural cavity as well as out, okay? So as a non-first responder and you're on that scene, you got plastic wrap. You can place it over the wound to keep the air from coming in. Do you want to tape it down on all four corners or not? If you leave one corner free, it's thin enough that when they breathe in, it pulls the plastic wrap onto the wound, and that blocks air from coming in. But if you leave one corner free, when they breathe out, that allows the air to escape. And it's not really a chest tube, but it's kind of acting like that as it allows the air to be forced out but not pulled back in again. Okay? So, this isn't going to save your life necessarily, but it might save somebody else's. You get 4 points of extra credit if you can send me a picture or sometimes show me on your phone a picture of some plastic wrap and bandage tape, like white adhesive tape, that you keep in whatever you travel in. Your backpack, if your bicycle, or the back of your car or something, okay? You can just send me an email with that, and I'll trust that it's you and not everybody using the same picture. Or you can show me on your phone sometime between now and our respiratory urinary system exam. Alrighty? Okay, let's stop there. When we come back, we will look at factors that affect pulmonary ventilation and pulmonary volume, which is what we're going to measure for lab next week, but we'll look at that tonight. So what I want to do now is break our lab into 2 periods. So we'll take the quiz at the end of this break. So let me know if you want to do it in 2 minutes or in 30 minutes or in 45 minutes. I'll work with you. Then we'll come back and finish pulmonary ventilation, all right? And then we'll do the sheep blood dissection. And that will be what we do this evening. All right, our quiz next week is still on this material, and I'll remind you what that covers. Mostly histo, but we'll probably have the parts of the lung that we finished up with today. So today's quiz goes from nasal cavity to the cricoid cartilage of the larynx. So there's nothing from trachea on, all right? So it's laryngeal cartilages, muscles, and nerves. The pharynx, so constrictor muscles, the oral pharynx, laryngopharynx, spaces of the nasal